At this time, when hospitals are extending care beyond their walls and optimizing workflows to improve the quality of care, seamless data integration is essential. In this session, you will learn how health systems are sharing data and leveraging interoperability to support a patient's seamless journey across healthcare settings. The moderator for this session, Claudia Williams, Chief Executive Officer of Manifest MedX, will introduce our panelists.
Great. Hello, everybody, and so great to have you here today. I'm really excited to be joined by a stellar panel. We'll start with Bob Darren, Chief Data Officer at CVS Health and Aetna, as well as the Chief Analytics Officer at CVS Pharmacy. We really look forward to his comments. We're also joined by Dr. Bala Hatta. He is the Chief Analytics Officer at Rush University Medical Center, as well as by Andrew Kasarskis, the Chief Data Officer at Mount Sinai Health System. So we're excited that all of you are here today and joining us for this important conversation. I'd like to start out by kind of the ends and how we're thinking differently about those ends. So what I mean by that is that we're all in the business of sharing data and interoperability as a way to break data silos. And really, we don't care per se about those silos, except that they disrupt what we are trying to impact, which is the care of patients and the public health of our communities. So I'd like to talk a little bit about how the insights we've gained during COVID have shifted our thinking and our strategies about that important silo breaking activity that we're all in. And I'll start just by way of example. Manifest MedX is a health data sharing network in California. We connect data for about 26 million people, including 100 hospitals and 8 health plans. And one of the realizations we've had during COVID is how critical networks like ours are in actually creating connective tissue across public health and clinical care. And I'll give you an example. We are seeing very much right now that providers and plans, this is very much the case in California, don't know when their patients are vaccinated because luckily, like me, they go to CVS and they get vaccinated, and there's not a good way to relay that information back to providers. So one of the critical functions that health networks have, we maintain the patient lists of all the providers and plans, and we can push alerts and reports to them about who's been vaccinated so they can optimize their outreach activities. Similarly, in another boundary spanning way, often those data are populated without all of the information that's needed. For instance, we don't always know the race, we don't always know, up-to-date contact information. And likewise, there's not a lot of insight, there's no insight about the previous health history of patients. So as public health is looking to do things like tracking the morbidity of patients over time, looking at vaccine side effects, or even trying to look at equity issues, having that connected tissue that connects clinical care and public health is equally important back to the public health side, right? So I'd say our key realization is that we can play a really important role in being one of the intermediaries that can sit between community health and public health and the clinical care that's more focused on individual patients. So to you guys now, I'd love to hear about one thing that's really shifted in your data and interoperability strategies. And starting with you, Bala, you said scarcity among abundance is the characterization of what's going on. I'd love to have you use that quote to kind of talk about what's shifting for you guys. And after him, we'll go to Andrew and then Bob for your insights.
Well, great. It's great to be with you. And, this is, we really, so I think in the last year experienced the sort of lowest common denominator of what data is shareable, because it was a little over a year ago, and I know here in Chicago, we were like actively looking on Twitter just to really understand what was going on with clinically in New York, and in Seattle and in Italy to see what were the clinical characteristics of patients. I mean, we experienced that lack of information. And I think COVID really brought out how urgently you need to know. And, we're a large transfer center in Illinois. We receive a lot of transfers, and even understanding regionally what beds are available and what's the situation in terms of available tertiary care beds, which we know links to outcomes. That was a huge need. So, one thing we did that we're proud of is we partnered with the health department and tried to build a consortium around hospitals in the city of Chicago, something we called Chicago Department of Public Health Data Hub. And by leveraging standards like HL7 standards for meaningful use, CCDA, data exchange, the health department has actually built a COVID registry that also has bed capacity. And we try to leverage that to be able to understand regionally what's going on. And it's been an enormous learning experience about how to improve the interoperability with public health.
Wonderful. Thanks so much, Andrew. Love to hear your insights.
Yeah, so really there were two things regarding data I think that we learned in COVID-19 that were probably always present, but it's so much more brought to the fore. The first was that teams function a lot better when they actually have timely and accurate data. And the second was it really pays to have invested in scaled infrastructure that works 100%. The beginning of the pandemic, of course, it began first and hardest, and there's a real actual epidemic in the United States, in New York City, and we were in the middle of that. It was a very difficult time because there was inadequate space, essentially no testing to speak of that was available, and very little knowledge about what to be done clinically. So to try and facilitate matters, we actually immediately got all the analytics groups and whatever we needed from the clinical teams as well as the analytics and software and engineering teams together in a morning meeting every morning at 8:30 to talk about what we knew. And we rapidly discovered actually that the semantic correctness of the data was very important. The definition of what is a COVID patient, what is a suspected COVID patient, what does PUI mean, who's using it to mean what, how do we know if we've got a ventilator available? All those things actually were novel vocabularies that were being used differently and needed to be harmonized. We spent a lot of time on that just via human communication, and it really helped. And then as we got that structured, we could report on it. Then the next thing, we had a mixture of hospitals that were on our single EHR Epic and some that had not yet been transitioned. The cost of obtaining data that was accurate and reliable was so much lower in our target system than the other ones. That's not because Epic's better than any other EHR. It's that that's the one we standardized on, and that's the one for which we had the reporting capabilities. So, going forward, we're going to keep the energy where we can of the communication across silos with the teams. And we're going to put a lot of effort in making sure the infrastructure is there and simplified wherever possible, because that makes you ready for the next crisis.
Great. Thank you, Andrew. What about you, Bob?
In a very pleased to be here. Really excited about the session. But I think similar lessons of the importance of connectivity, the importance of understanding your data. And we certainly learned very quickly in the midst of the pandemic the ability to understand the external environment with much greater speed than we ever did before, of what's going on in the healthcare system. How do we, we'd always look to external websites. We now need them every single day at a speed we just weren't prepared to get them before. Developing APIs, developing connections and networks. Our own internal capability. CVS Health is a big company made up of different business units. The understanding of our stores, our clinicians, our employer groups, of how the pandemic is hitting our company in different ways was a huge eye-opener for us, of data we never thought was as critical to manage now became daily critical that we need to report even up to our board of directors of how we're being impacted by the pandemic. But the one thing I'll draw upon sort of within the more recent experiences on the vaccine distribution, where CVS Health, along with other sort of pharmacies and many of the players, is sort of integrated involved in sort of the vaccine distribution efforts, and how difficult it was, or how many challenges there were of connecting to the rest of the healthcare system, particularly as the vaccine distribution started of long-term care facilities and assisted living, and understanding even how do you define those facilities? What's the bed census? What's the occupancy? What's the forecast? And to effectively develop a national strategy to distribute the vaccine for different parts of the healthcare system, I think it brought a lot of lessons to light of sort of the things we could do well, but also the things we had never really made the connections of different parts of the healthcare system. We think we did. We have made a number of huge strides of getting the vaccine out, but certainly we learned a lot of lessons along the way of the gaps and how to close those incredibly quickly in terms of different parts of the involved in the vaccine distribution chain.
Well, that's a great segue. And I think what I love about your comments in general is there's like the actual patient level information we share, and then there's the meta information about how we define things and whether we share those definitions. And what we learned, I think we knew already, but if you don't have common definitions around what a case is, what a bed is, what an open bed is, what an ICU bed is, then it's really hard to figure out what your capacity is and where things are moving. So on this vaccination issue, where I know this will be actually aired a little bit later, but we're at the doorstep of, we've opened up vaccination to all adults, everybody over 16. That's happened quicker than I think anybody thought. And quickly, we're going to move from a mode of scarcity, where people like me were searching on the CVS website at 3 a.m, to one of abundance, where the issue is going to be more reaching people who haven't been vaccinated. So the shift is going to be really fast, I think, as we move into that. So the two issues I think the nation is focused on, and each of us is focused on, is speed and equity. How do we move faster ahead of the variants to get everyone who's eligible a vaccination? And how do we do that in a way that doesn't leave anyone behind? So what I'd love to hear from each of you is your insights and what you're doing, or your lessons learned about speed and equity around vaccination. And I'll start with a little anecdote from Manifest MedX. So unfortunately, we do not receive at a population level. A lot of our peer HAEs receive daily downloads of IAS vaccination data from the state registries, and we don't yet. We're still crossing fingers that we will, but we are getting regular downloads of vaccination data from some of our health plan partners who get it from the state. And one of the things they found is they actually had a clinic that called them and said, we have 1,000 appointments ready to give them to you. Send us your members. And they literally made scores and scores and scores and scores of phone calls and found a handful of people ready. And I think that points to the need for much more proactive and organized efforts on outreach. So far we've existed on people getting to us, but we need to do outreach. So we've actually been taking their vaccination data, combining that with contact information, combining it with race information, adding in morbidity information, and sending them ready to go reports to support outreach that they've actually been handing off to a company that specializes in culturally competent outreach. So again, it's an example of the vaccination data is not enough. You have to combine it with other context and then put it in the hands of an organization that specializes not in passive reacting, but in the kind of active outreach that you need to have. So would love to hear, starting with Bob, just given the central role that your organization has played and continues to play nationwide. And then let's go to Dr. Hota and Andrew to respond after that.
Yeah, happy to start. So the issue of health inequities and access and outcomes is not a new topic, but it certainly became much more to the forefront in vaccine distribution, and one that was incredibly tangible, sort of how well we could measure sort of how well the vaccine is getting to different communities. So we certainly had planned for this as part of the vaccine distribution. So in a number of variables, we've got obviously constrained supply, we've got different state mandates across different distribution strategies, and how we want to, in different sort of communities we deal in. So we actually had a very thoughtful plan of how to make sure that we had equitable distribution of where the vaccine goes, and we executed on that. But I think what we found is that wasn't enough to get to the communities most in need, most vulnerable, most sort of most underrepresented in terms of vaccine access. And we actually had to complement that partially with additional data. So not just where the communities were, but understand contact information, how we identify those people, but then actually connect it with our community efforts, other types of outreach, other groups that could help not just ensure that the vaccine went to local areas, but we actually promoted sort of how do we make sure the awareness, the appointment settings, we thought about sort of what is going to take to sort of get the vaccine distribution as equitable as you can, and really focus on those underrepresented groups that historically hadn't had as high rates of uptake. So that was a major shift. And again, I think it's one of the things that we learned, just about everyone's learned in COVID. What might have taken quarters or an annual plan was done literally in days and weeks. We could actually shift our strategy. How are we much more agile? How do we connect data? how do we react in literally sometimes intraday as new announcements came out to adjust our strategies. So all of those were critical components of our strategy. But it's also I think it's going to be a long-lasting effect. I think the thinking is sort of how do you organize, at least from our perspective, the delivery of healthcare services at a community level and understanding all the different characteristics and of that community and sort of all the different ethnic, racial, minority groups that particularly that historically have been underserved, and addressing strategy. I think we're really excited to take that forward, what we've learned, and apply it more broadly.
Wonderful, thanks.
And I feel like we've lived the experience of that both of you guys have mentioned, and Claudia in particular, how you talked about the effector arm and where the rubber meets the road is the actual distribution of the vaccine and by providers. That definitely came up for us as a health system. We're fortunate at Rush in that we have health equity measures built into our routine dashboard. So our balanced scorecards have race, ethnicity, language, and where you live as part of our outcome measures to ensure that we're sort of performing well or see where we have gaps. And that's been a corporate focus as part of our strategic plan. So that ended up rolling into, as we monitored vaccine inventories and distribution, that just rolled into that. And the way Chicago, the rollout went is, there were a few major academic centers that had had the freezers to be able to handle having the, Pfizer vaccine and be able to store it. And so we ended up being sort of at the front edge of getting inventory. And so this ended up fitting into our overall distribution plan and the way that we were approaching kind of health equity to begin with. So we actually used the data to look at our current population, look at the current tiering from the city in terms of who's eligible to get the vaccine, what are the comorbidities for people who are, in subsequent tiers. And we ended up queuing up individuals to know who to notify. And we had banks of, 10,000 people that we would start notifying over time. But again, then it intersects with some other things like MyChart adoption. We're an Epic shop, and so the use of the Epic patient portal. And we quickly rolled out scheduling, Epic scheduling through MyChart, which we had never had. So talk about, fast change management, that happened. And then we really tried to align with the city. The city rolled out something through ZocDoc, which was a standard interface for appointments. And so we made those available as well, because it really ended up being an issue of knowing where to go and what website to go to. And so it was good that they were trying to make that a little more friendly. So I think we multifactorial, but it has really been how we get to the actual neighborhoods to roll out our vaccination that's been critical with the data.
Great examples. Andrew, what about you?
Yeah, so I was involved in our vaccine rollout in a very supportive role. It was led by our Chief Pharmacy Officer, Sue Mashney, with aplomb, and she put together a team very early that involved our diversity office as well as our marketing and communications group to ensure that we first surveyed both internally to our own employee population as well as the community at large to understand issues around vaccine hesitancy, adoption, understanding, those sorts of things. We then quickly identified from our own very, very diverse workforce, individuals who were understanding and supportive of vaccination, who could then serve as ambassadors both within our community and then in the broader New York City community, and equip them with promotional materials to get the word out there and get the education out there. That's all very important, that's all very good, but of course that's not the data part. The data part comes in with how do you actually figure out how to allocate a scarce resource to ensure equity. And we have many patients in our community who do not have internet access regularly, cannot be relied upon to navigate websites. And that would pretty much have been a dead letter. So what we did is we took our ACO risk stratification models and we updated them with coded comorbidities in line with whatever the guidelines were. And then we randomized actually. And rather than, we sent an electronic notification, sure, but we also did an enormous amount of phone calling to get to people and tell them this is where they need to be, and ideally from an ambassador who understood them, their community, their language. And that, was a good thing, and I think it helps certainly over not doing that. But there are a lot of people who are not going to be reachable even that way. So we had a parallel effort going where we tried to leverage our visiting doctors program, where we provide care in the home, our free clinics, and things of that nature, as well as standard community outreach through religious organizations, vaccination on Sunday after church, that kind of thing, to really get to the communities that otherwise would not have been reached. And all of that actually depended crucially on a up-to-date list of definitions for who was eligible, which was changing all the time, integration of clinical data, which actually had some information as to what those comorbidities were, basic patient demographics, and up to, as real time as you could make it, information on the inventory of vaccine, the staff who could actually administer it, the location of vaccine, the location of patients, all of that. And that sort of integration of data is something that we had not historically done strongly, and we would like to continue doing going forward, not just for crises, but frankly for regular provisioning of basic care and allocating scarce resources such as primary care appointments that sometimes might not go filled. It's a thought we can learn from.
Wonderful. Thank you. I think what's interesting, I think this theme of data as connection between disparate communities doing different parts of the work involved, but also an increased awareness of the partners that you didn't know you needed, right? And so, especially when it comes to the really reaching people in a way that resonates with them. And I don't know that all of us had those organizations in our networks in our sort of line of sight before this. I'm going to maybe make a bit of a harsh transition. In the middle of all of this challenge, some really groundbreaking federal policies went into effect. I expect some people wish they had been delayed. And I'm speaking about the information blocking regulations and other related regulations that the federal HHS put out. So those came into effect just in the last week. And I think they caused a certain amount of both excitement and hand-wringing across the board. I also expect that, like HIPAA, when it first was instantiated, it's going to take a little bit of time to see what the actual impact is. But I'm curious, within your organizations, what kinds of shifts are you making, either in policy or approaches, to respond to these new regulations? And I'll go last here, but let's hear from Andrew first, and then Bob, and then Dr. Hota.
Right, so this actually was very exciting for Mount Sinai. New York is a very, very complicated healthcare ecosystem where most patients get their care lots of places, and many of our patients get services that are health related that are not even from standard medical providers. So we have been eagerly awaiting the information blocking provisions for a long time, because we firmly believe that if we're in the business of providing evidence-based medicine, the more evidence we can get, the better off we'll be. And we're often dealing with situations where we have limited information on patients. So we were very excited about that. We've been preparing for it for years. And we did not have major issues. There was some plumbing, things that needed to be done, but Bruce Darrow, my good colleague and our chief medical informatics officer and team, had really, I think, pretty much had that nailed down. So, so far so good. We're excited about it. We do think that if patients can direct where their data needs to go, that will improve the quality of care no matter what. And that we will be better physicians and better practitioners if we have the data. And I think this is a matter of great national importance. There's a paper that came out in the Proceedings of the National Academy of Sciences just, in early April by Preston and Veerboom. You may have seen some of the news coverage on it, which basically looked at excess life lost in a typical year in the United States relative to a basket of, I think, 5 European democracies of similar population. And we come off very poorly and worse in 2017 than 2019. Hundreds of thousands of extra deaths. And if you look at the years of life lost, it's much worse than COVID, because COVID disproportionately strikes down the old, whereas our excess deaths typically strike much earlier in life. So, some of that's probably access to care. I doubt a whole lot of it's actually, quality of care. I think a lot of it might have to do with interoperability and coordination of care. And so I'm hoping that we might be able to see that number come down in the future as a result of better integration of data across care providers.
Thanks so much. What about you, Bob?
Yeah, sure. It was it's been a big compliance lift for CVS Health, in particular Aetna Business. Sort of, we had some of the regulations obviously in place. Some of the other, around payer-to-payer transfer and transparency don't hit the payer world until late sort of in future years. But I think it's been an eye opener and a continuation of the strategy we already been investing in about connectivity. So I think so. CVS, like our colleagues on the panel, we're an Epic shop. We have all of our minute clinics on Epic. We put all of our clinical programs on our enterprise on Epic, with one of the major goals to be able to share that data we're collecting within CVS Health with the outside world through sort of standard interfaces. And I think it has dramatically increased the level of excitement about patient directed sharing of data, where we can actually connect data across the ecosystem, because we know that we've got a sort of announced strategy to sort of continue to sort of bring more and more services into retail healthcare, but we think that's only going to be effective if we can share that data with the rest of the with the rest of the ecosystem, with the patient's primary care physician, with other providers. So we're making big investments like other payers are, but it's something we think is going to be a big bonus, a big accelerator for the healthcare system, and really starting to make healthcare services, healthcare consumerism, patient empowerment, all sort of going to be enabled by sort of the new interoperability regulations. And I agree, it's going to take time. I think people expected, like, it flip a switch, the world changes. But over time, as the ecosystem develops, as more interfaces are built, as more players come in and help patients manage their data and manage their sort of where they want their data to go, we're really excited, and we are looking forward to sort of how do we connect to that ecosystem. We think it's going to help us support the services we all deliver. Most importantly, the patients that come into CVS, or we serve through Aetna or other businesses, we can actually deliver a more holistic care experience and then share that information back with the rest of the healthcare system.
Great. Bella, what about you?
Yeah, we're very excited for it. I think the consumerism piece of this, I think for our patients is really going to be huge. We are an Epic shop, and we're leveraging the Epic Fire server and the way that the fire services are enabled through Epic. So we are already compliant with where we need to be, but to be able to innovate the sort of apps that may be available, and the way that the data gets presented and sort of that end use cases, I think there's just so much opportunity to innovate on this data store and set of data stores that could be available. So I think it's really great that this was done at the federal level, and I mean, it's almost about time. So we're very excited.
Well, I'm going to add my 2 cents on this concept of patients having access to their own data. Interestingly, health information exchange networks have not typically given patients their data, even though we have what is often the best combined source of unified data around the patient. And some of that has been because, honestly, our partners don't want us to, because they have their own relationships with those patients, and we don't, right? We don't have any relationship with the patient. And some of it's just been, I think, a technology issue. So we, perhaps in baby steps, but in the rules were very clear in saying HIEs have to give access to patients. Unfortunately, our contracts often block us from doing that. And so what we've put into place is a somewhat convoluted method where a patient has to get authorization from a provider. But honestly, what we're hoping for is that the federal government steps forward and says any contracts that block patients from getting their data are null and void, right? Because otherwise, all of that burden is on us to go figure that out. So we're super excited that we're going to be able to offer this unified health record to patients directly. And we actually hope for additional federal action to make that even easier. I will say, though, we met with a group of doctors last night and we updated them on this, and they were like, hold on a minute, you're going to share our data with patients? And I was like, just a minute, that is actually not your data. That is their record. And they already have a right to that data, right? But I think that way of thinking that this is a doctor's record, and that's understandable because that's always been the way we've thought about it. But I think increasingly this moves us in a world where it truly is the patient's record and not just the health system's record or anything else. So, but still a bit of culture change I think we have to go. Okay. This has been a fabulous and fast-moving conversation. We have just a few minutes left, but I'm going to ask you to play boss for the day of the world. And if you could make one change, either in your own behavior or in policy or in the way things work, that you feel would go the farthest in accelerating the outcome we want, which is really the better health for patients, what is the thing you would choose to change or create? And I will start with Dr. Hota and then to Bob and Andrew.
What a great question. Well, I think being in the data field and linked to this last topic, I would accelerate. I mean, to the extent that we can accelerate the liberation, the liquidity of data to go to patients, that really, I do think, has an enormous opportunity to just transform what we do. You know, this is a healthcare transformation summit, and so it really could just open up. And what COVID has shown is that things that we thought were really hard and could take years can actually occur very quickly. I mean, the telemedicine, you know, our net promoter scores for telemedicine visits are, you know, through the roof. People love it. And we fought that for, you know, 4 years and all the reasons you can't do it. And overnight we did it. And so I think we're at that tipping point. So it's data liquidity.
Wonderful. Bob, what about you?
Yeah, so great question. I think in general, sort of coming from an analytics with a data background, sort of getting to standard machine readable coded data sets that we can understand a level of detail that are in all the unstructured data that's out there about the patient experience, about clinical treatments, around images, around notes, a lot of which obviously is being turned into sort of analyzable data through more advanced machine learning and artificial intelligence. But the more that can be accelerated, so we get to common sort of standard analyzable data sets, that helps us understand that is captured with patient consent is used. We understand much more, very complicated questions about sort of what works and what drives better outcomes, not just clinically, what drives outcomes in terms of behavior change. And I think there's obviously a lot of clinical research, but one of the hardest things to understand in research is what things drive behavior change at the individual and patient level that then leads to better outcomes. Like, how do you influence, how do you nudge, how do you get patients to sort of get more engaged in the healthcare and help them drive their own healthcare outcomes, working with the healthcare system. I think that's probably the one sort of wish list and dreams I would have. If I could sort of cheat for a second. The other piece is a little bit more practical and less but is around really getting integration with provider data and data about provider systems, which is not sort of necessarily think about, drives a lot of sort of clinical outcomes, but causes a lot of administrative inefficiency coming from the payer side of just how much effort we sort of have to sort of understand providers, credentialing, networks, addresses, and keep that up to date. Which if we could sort of figure out how you could create that, which I don't think it's necessary, but if you could take all the effort we do of standardizing that data and turn it into figure out how we push towards better patient outcomes, we could make a lot more. It would be sort of even have to help accelerate that even further.
Great. You did sneak in two there. I thought that was pretty clever. Andrew, and we'll maybe just 1 minute for you.
Yeah, so absolutely. I can, I think, be quick. I mean, I'm sort of trying to synthesize what Bala and Bob both said here. And I think in the future, we want data to flow through the healthcare ecosystem in a frictionless and patient-directed way. So what can you do to do that? And if you do that, of course, obviously it'll facilitate all the analytics. It'll be more usable. It'll be more omnipresent. It'll be higher quality. So I would actually say that we ought to go back to school and get the basics right. And it's one thing we might want to consider actually is a single unique identifier for each patient, each person. We all learned in school, every single first database book we looked at, you need a primary key, it needs to be unique. We don't get in this country. And if you want to ask why the Europeans have less tests than we do, it might be because they actually can count people and make their medical records follow them. It's worth considering at least.
Great, Andrew. And I think there is a rising set of voices that are asking us to look at that and reconsider that issue. I'm actually going to shift gears a little and say, I think we need to speed up new forms of value-based payment, because in the place I sit, which is at the painful intersection of practices and hospitals and health plans, I would say the biggest blocker is lack of business alignment. That creates a lot of resistance to things, not because they don't want to do that necessarily, but because it doesn't create an outcome that's financially viable for the organization. So I'd like to see the federal government and states and payers all and health systems all moving with more urgency towards more more holistic ways of paying for healthcare that will create the partnerships and data sharing that will benefit patients, because I think fee-for-service is toxic when it comes to patient outcomes. So that would be my thing. Thank you all so much. This has been a lot of fun, and we look forward to questions from the audience and staying with you for a discussion with all of you. Thank you.
There we go. All right, folks. Well, our speakers are going to get their microphones and cameras on, but my name's Adam Ribbenfire. I'm a content strategist with Modern Healthcare. Thrilled to be here. There we go. We've got Bob, we've got Andrew, and we've got Bala. And yep, there we go. Excellent. Well, it's good to have you all here. Thank you so much for joining us, gentlemen. Claudia, unfortunately, could not be here today due to prior commitment, but you've got me. So I will start with kind of, we want to understand where priorities lie kind of in closing data sharing gaps. And audience, I'm going to ask a few questions, but please continue to send them in. We want to know your biggest interoperability challenges, what you're trying to solve. We've got three really fantastic healthcare leaders here who can offer the solutions they've found on their end. So, and Andrew, I'll start first with you. New York City was really an epicenter for the pandemic. And so I'm wondering if you had to prioritize one data sharing gap to close, that we can close to ensure we're prepared for the next pandemic, what would it be? What were your kind of lessons learned?
Boy, there are so many. Honestly, basic information about the social history of the individuals that might be important for their care, I think is probably the hardest thing to track. And so that is probably a place that I would go. It's we're humans, we're social creatures. COVID-19 was a very lonely experience for many, and doing a better job of being able to integrate that would have been really helpful.
I think we forget about social exclusion as a key social determinant of health that doesn't often get pointed out. So absolutely agree with you on that. Bala, what about you? What would be your kind of biggest priority closing data sharing gaps to ensure we're prepared for the next pandemic?
Well, I think, the linkage between the facilities and the health department. It really did feel like we were sort of building that in real time, and being able to make sure that when the health department needs something to help with its surveillance efforts, there's easier mechanisms to get that data in its hands.
Yeah, I live in Chicago like you, and I definitely noticed we saw the health department working with some hospitals, frankly, some problems that the health department had with certain hospitals, and you're totally right, kind of making sure that flows easily and the data that the health department has is accurate. That makes total sense. Bob, what about you? What comes to mind in an organization like CVS Health, your role in kind of combating the next pandemic? And you're muted. Button at the top left. Under the camera. Okay. Oh, we may have lost him for a sec. In the meantime, I'm going to go around and ask just one more question. Same idea. Oh, there he is. That might have been your camera button, Bob. You've got a microphone button under it. In the meantime, Andrew, I'll ask you, if you had to prioritize a data sharing gap to close related to health equity, what would that be? So
first of all, almost everything is kind of related to health equity, right?
Right.
So,
we talked a little bit about social exclusion already.
And access to care is a real big deal, and trying to understand the barriers to access to care. Telemedicine was very important in COVID-19. It continues to be very important. Not everything is all about who's got a stable internet connection. It's also who's got privacy in their space where they want to be able to actually have a video encounter. It is actual effective ways that are non-discriminatory based on socioeconomic status, which correlates with so many other things, to actually engage with patients through all the channels that the most privileged enjoy. I think that is, when you have to go to someone's house, when you have to come up with an alternative solution for a video link, those sorts of things are stuff we have to explore.
Great. Bob, can you hear us?
Yeah, sorry about that if my computer froze up. But anyway, I did hear you. So, yeah, I think the question, I think it's, of all the data sharing, I think it's probably the one that we struggle with the most is novel ways to share data with government agencies. And we had great working relationships and but we hadn't gone through the crisis response of how quickly we need to develop those connections, place we hadn't thought about before. So I would say, again, we had an enormous amount of participation and partnership with, across both federal, state agency, registry, CDC, but the communication protocols of how we share data with each other largely had never been built except for some well-defined pathways. So I think, that's the place, and, in our company, many others really have upped our crisis preparedness. I think how we sort of work across the system, particularly with, the government health systems and agencies, is probably something we need to keep getting better at.
Great. Bala, what about you? When it comes to health inequity, I mean, I know on the West Side, there's any number of, of nonprofit organizations and other. There's a lot of medical providers on the West Side, and I'm just curious how your thoughts on what gaps are important to close to improve health equity. Excuse me.
Sure, absolutely, yeah, and I think. So we do on the West Side have a great Illinois medical district, and but yet there are these health outcomes differences that persist, where there's a 13-year life expectancy difference over 5 miles. You go 5 miles in the city, and it's this huge gap, and I think we don't really know how to measure. Honestly, like going all the way back, we don't know how to even measure the basics. The things we do measure are surrogates for other things. 80%, of the care of the outcomes difference is due to the healthcare things outside of healthcare, and so things like health risk assessments, or how well are we doing surveys for these social determinants on patients getting registered, and just building that into our daily practice of clinical care, then it'll be there when something like COVID comes along. So we actually, I don't think we even collect the right variables to even understand the problem at a baseline.
You got to collect the data first before you even get into what we need to share. So go ahead. Sorry.
Oh yeah, and it totally goes to Andrew's point. I mean, around isolation and other variables. Like we just don't. And in a crisis like a pandemic, it's really hard to spin up something new. It ends up being super reactive, takes a long time. How great would it be if we make the change now as things are receding? Absolutely. So when we think about, what the ideal future, I feel like a lot of times when we talk about interoperability, it's this pie in the sky, and we talk about what could be possible. So I'm going to ask you to paint that ideal, that pie in the sky, and what we should be, where we should be, and tell me how far away are we from making that a reality? Hopefully not too far, but I'll ask Andrew. What is an ideal state of patient data sharing look like, and are we anywhere close to it?
Okay, so this is one of these things that you can never do. You can never stop doing better, right? So,
right.
Taking a bit of a hint from Bob, communicating with the federal government and everybody else in a coordinated way would be great, right? And that actually starts in part by simply talking about what it is we're going to talk about, right? What is the concept? What's its definition? Making sure that everyone actually encodes the data the same way. Then it's easy to share. We struggle with that inside our health system. I can't tell you the number of times we had discussions about, how we define a PUI patient and a suspected COVID patient, and how that changed, sometimes hour by hour, right? But if you don't actually have a clean definition of what it is you're talking about, you're never going to be able to compare things fairly and accurately, and you're never going to be able to see trends that are real. I think focusing on a somewhat limited number of the key variables and making sure that they're all collected and shared and compared fairly is probably a good place to be. And that facilitates everything else in terms of, ultimate randomized studies and meta-analyses of data across systems and all those good things.
Awesome. We're actually getting to the end of our time, so we're at the end of the session. So unfortunately, we do have to go. But audience, we're looking forward to having you at the rest of the conference. Thanks so much to our panelists for the time you've given us today and such insightful discussion. Thanks, audience, for your questions.